medication-assisted recovery. Some of you might know that as medications for opiate use disorders, or it's known as several names. We in Illinois like to tag it as medication-assisted recovery, or MAR. And so we want to increase access in marginalized communities who are experiencing the brunt of the overdose crisis in Illinois. People from marginalized communities who could benefit from starting medications for an opiate use disorder or polysubstance use often find barriers to treatment that may sound familiar to barriers found in rural communities or other communities. Lack of accessible treatment resources, lack of transportation, and stigma related to their drug use can keep people who could use services most from accessing them. In addition, marginalized communities across the state are experiencing the disparate impact of the overdose crisis, while MAR, or medication-assisted recovery, can help reduce risk by up to 50%. The line between crisis response and living in a state of continuous crisis blurs what mobile services can provide when considering substance use disorders, due to the immediacy of risk and the precarious position people who use drugs are in. Even though the risk of morbidity and mortality is high, drug use that develops into a substance use disorder does not respond to what most people would consider logical decision-making. Substance use disorder is characterized by a hijacking of the brain's reward centers and the reduction of the brain's executive function capacity. Staving off withdrawal symptoms becomes one of the main drivers of continued drug use. Yet, people can still engage with others and respond to non-judgmental access to services. And we see that over and over again. So today we have a fantastic panel for you that will present on and discuss the current mobile unit services partly funded through SUPER. We are joined by Dr. Nicole Gastala, the medical director of SUPER. Dr. Gastala is board certified in family medicine and addiction medicine. She graduated from Loyola Stritch School of Medicine and completed her family medicine residency at the University of Iowa. In her clinical role, she has developed and expanded MAR by mentoring new prescribers, precepting residents, and training clinicians within Chicago and Illinois communities. She has also focused on the development of a walk-in integrated behavioral health, addiction, and primary care program within her FQHC system. We're also joined by Dr. Sarah Messmer, Dr. Abigail Elmes Patel, and Albert Murphy of the amazing team at the Community Outreach Intervention Projects out of the School of Public Health, University of Illinois, Chicago. I'll start with Dr. Messmer. Dr. Messmer is an assistant professor of clinical medicine and pediatrics and is board certified in addiction medicine, internal medicine, and pediatrics. She provides primary care for adults and children at UI Health, as well as low threshold substance use disorder treatment on Chicago's West Side in a clinic developed within long-standing syringe service program. She is co-PI and clinical lead of the COIP Mobile Medication Assisted Recovery Program, which provides primary care and substance use treatment via mobile van at overdose hotspots. Next is Dr. Abigail Elmes Patel, who is a doctor of pharmacy, holds a Master of Health Professions education, and is a board-certified pharmacotherapy specialist. She works as a research assistant professor at the University of Illinois, Chicago, Retsky College of Pharmacy Practice, is a member of the Institute for Research on Addictions at the University of Illinois, Chicago, and family medicine clinical pharmacist at the University of Illinois Hospital and Health Science System, with a practice site in street medicine. She has also served as Fellowship Program Director for the UIC Academic Family Medicine Fellowship since 2022. Dr. Elmes Patel received her doctorate in pharmacy from the University of Pittsburgh, completed 3 years of postdoctoral training, and leads a fleet of medical mobile units dedicated to delivering life-saving opioid use disorder services. Her hands-on experience includes responding to community overdoses with naloxone and coordinating care transition with first responders. And then next on the panel is Albert Murphy, who holds a Master of Public Health with a concentration in health policy and administration. He has been with the University of Illinois Chicago's Community Outreach Intervention Projects, or COIP, so you'll probably hear from it from now on.
Yeah, it says that's when
spelled out as COIP.
Change the view.
For the past 10 years. He began his journey as a student volunteer and has progressively advanced to the various roles in outreach, research, and HIV and Hep C counseling and testing. Currently, Albert is the program coordinator for COPE's mobile medication for opioid use disorder, or MOUD project, and is deeply committed to public service. You can find all our bios in the bio packet as previously stated. So the panel will answer several prepared questions, and then we will switch and leave the last 15 minutes of this 1 hour session for questions. Please write down any questions that you might have so you don't forget them. You can put some questions in the Q&A if you like, and then keep in mind, or you can keep some of those questions in mind for the last 15 minutes. So I'd like to start out with Dr. Gastala. Dr. Gastala, from a state point of view, what was the impetus for developing this model and deciding to fund mobile units?
Thanks so much, Dr. Rivera. So one of the impetus for this was, this occurred initially during COVID, which then created barriers for patients to access treatment services, right? So it exacerbated the challenge of accessing services that we saw before, and it was even more difficult during that time because of sheltering in place. Different places didn't necessarily have as many openings anymore. And so that became really difficult for helping our more marginalized patients, right, access services. And so the DEA and federal government and state had relaxation of guidelines, which then really allowed the ability to dispense medications and deliver medications from mobile units. And so that's sort of the impetus that started. It was really seeing a need in the community, figuring out a way and having the right time to be able to do it. And then also the funding, right? With the COVID relief funds, we were able to fund units and staff to be able to meet this need during that time.
Dr. Rivera, you're on mute.
Thank you. So thank you, Dr. Gastala. And your statements about funding actually bring us to the next question, which is, do you think that these units have made a difference? And do you see these services continuing, considering the federal changes and the funding that is needed to maintain them?
That's a really great question. So I definitely think that these units have made a significant difference, and you'll see some data from the COIP team, but we've also seen this in other states as well. There's been, posters and publications that really have shown how it can impact patients and really improve access to services, and not just, medication-assisted recovery, but harm reduction services, primary care services, preventative services. So again, really bringing services to those who need it the most, and really reducing those barriers in terms of access. The challenge is, as you can imagine, and people can imagine on this call, is the funding piece of it, right? Most of your patients, perhaps that you're hoping to interact with, are uninsured or maybe Medicaid or don't have well-paying insurance. And so trying to sustain this through billing models alone can be really challenging. And so it really does take a braiding of funding, right? Trying to bill for what you can, trying to get federal funding, foundation funding in order to offset the operational costs of mobile units, because though they do a great public health service and really are impactful for patients, it can be, a cost to that. And that's one of the my hope but also concern over the next few years is what's going to happen with federal funding for some of these services and how that gets relayed down to states to then be able to continue these great programs that we started during the COVID era.
That's a great point, Dr. Gastala. I think it's an ongoing concern for so many of us. So, how do you see these services building on a harm reduction and or crisis-based continuum service?
What's really great about these services, a lot of times the organizations have already existed in the community and have already been providing, whether that's food or harm reduction services or basic other needs, right? Housing assistance, insurance sign up, right? So they're well-known resources in the community. And then adding the medication-assisted recovery component to it then allows for patients to, when they feel ready to make a change, that there is no barrier to making that change. And so there is a opportunity to be able to ask for assistance to get immediate access to medication if they need it, as well as other services. And I think that is the sort of the greatest impact, is being able to be there when a change is requested.
Fantastic. Thank you so much, Dr. Gastala. I'd like to switch over to the COIP team right now. And so this is for the COIP team in general. The COIP team will decide who will be able to answer. But can you provide a little background on COIP and the work it provided prior to the introduction of mobile units?
Hello. Yeah. Thanks for having us. And I want to introduce COIP. And so we were founded in 1986, primarily to address the drug epidemic among people who use drugs in particular. And we are housed in the UIC School of Public Health and we're Department of FE-Bio. And we have 5 storefronts throughout the community in areas hardest hit by opioids or drugs in general. That includes Uptown, the West Side, Austin community, Inglewood, the Southeast Side, and then, of course, we have mobile units. And some of the services that we offer includes like harm reduction services, syringe exchange programs where people can drop off and pick up clean syringes, but also get access to recovery support, food and clothing donation, rapid HIV, hepatitis C testing, and we opportunities to participate in research conducted and carried out by our staff who are from those communities and have a past history of substance use. We refer to that as the Indigenous Leadership Outreach Model, where the people who deliver the services come from that background and have that history of drug use. And in 2021, we started a clinic on the west side, offering basic MAT services, primary care, in addition to HIV and substance treatments. And it grew exponentially, and I think we started to offer things like STI testing and other primary care services.
Thank you, Al. I'm not quite sure, Al, would you like to talk a little bit about that Indigenous Leader Outreach Model?
Yeah, so a lot of our staff have been working for a really long time and have great relationships with people once they became training and how to deliver like interventions and motivational interviews and use these skills to go out and recruit people and deliver the interventions to the population.
Thank you so much, Al. Also, as far as services, what services does COIP provide through mobile units and where?
No, I can take that question. Sorry, Al.
So originally our services started on the west side. The mobile unit services started on the west side in 2021. We have a large Class C size RV that houses our interdisciplinary team. That includes a physician, a pharmacist, many different outreach workers, a security officer, and our driver. So we offer low barrier buprenorphine, primary care, wound care, COVID testing and vaccination back in 2021 and 2022. And we started dispensing buprenorphine directly from the vehicle in July of 2022. So to figure out where our mobile outreach would best be implemented, we use Chicago Department of Public Health data that shows hotspots of where and when EMS teams are responding to overdoses in the area. So you can see an example from July of 2021 here on the slide. We target those hotspots. We're also informed by word of mouth from community stakeholders. That can include people who use drugs or other organizations that are doing outreach in the area. So currently our West Side vehicle operates mostly at Van Buren and Pulaski, which is kind of that bottom pinpoint there in the yellow spot. And we also serve Chicago and Homan, a little bit around Chicago and Kedzie, which is that north pinpoint spot. So periodically we've shifted locations based on community needs. That could be migrant populations, different homeless encampments, or if there's been an uptick in overdoses in a certain area. The great thing about having a mobile unit is that it has wheels and we can go to that area directly. In 2024, we got some funding to expand our services. So we now serve the south side of Chicago. We operate various locations on the south side. They include 63rd and King, 111th and Michigan, 76th and Cottage Grove. And all of those locations have kind of shifted over time based on our patient census and the word of mouth of the organizations of people on the south side as well. So those services on the south side unit include harm reduction, primary care, low barrier buprenorphine, wound care, rapid HIV and Hep C testing, linkage to care, recovery support specialists, referrals for outpatient and inpatient treatment. And we also offer contingency management for stimulant use. We're a site for a study that's being conducted at Northwestern in collaboration with the Chicago Department of Public Health. So that has started in 2025.
That's fantastic. Thank you so much. Dr. Patel, as you see this variety of services that you're able to provide, are there some examples of services that patients usually request initially? Like, how is that engagement process?
Yeah, it's really useful that COIP has had harm reduction mobile units for a long time before our medical units. That was on the previous slide was our harm reduction unit. What you're seeing now is the mobile medical unit. So we often park in the same area. And so if someone is accessing harm reduction services like naloxone or syringe exchange or syringe service program, oftentimes they will do a warm handoff if they're interested in buprenorphine or OUD treatment, if they have a wound that maybe we can address. So a lot of our referrals will come from them. In terms of patient requested services, that's kind of changed over time. When we first started, it was a lot of COVID tests, a lot of COVID vaccination due to the nature, like Dr. Gastala was saying. But that's really shifted towards treatment for opioid use disorder. Now it's mostly people requesting OUD treatment via buprenorphine. I think that's a testament to our consistency or consistent presence in the community. People know that when they see this big blue van on the corner, they know that they can get care with us. There's also two kind of sides of the spectrum. Some folks are coming for non-addiction related medical care. And once they realize that we have an open kind of environment, patient-centered, we're non-judgmental, we really have a harm reduction focus, they feel comfortable with us, and maybe they are more open to seeking treatment for their opioid use disorder. On the other hand, others are coming to us for opioid use disorder treatment, but they also have limited access to primary care, and maybe they need a refill on their medication, or they have a wound that we could see, so maybe they would be more open to getting that care. We do see a mix in that way.
And then as far as the introduction of the mobile units, like you were saying that you've been doing harm reduction mobile services for a while, and then the newer mobile units were added. Have you seen that as a building upon the services that COIP had been already doing in the community, or changing the trajectory of your work, or informing the work in any different way?
I would say it definitely builds upon. Our director, Dr. Jimenez, has this big goal, right, of treating people across the spectrum of recovery. So again, our mobile units for harm reduction have been going out for years at this point. And so these new medical focused mobile units kind of provide us the ability to provide medical care in tandem with these harm reduction services. And so this really means that COIP can provide services across that spectrum, and realize that dream of providing the full spectrum of medical care for people who use drugs, no matter where they are in their path to recovery, directly in their communities.
Thank you. Also for the COIP team, what do you see as the effective or critical components of your model? As I think of mobile crisis units and the idea of having a presence and people knowing you in the community, yet also still being mobile services. I'm just wondering, what do you see as those critical components? What do you see that's working on the ground?
I can jump in with this one. I think probably the biggest thing, and both Al and Abigail have alluded to this, is the relationship that COIP has in the community, and particularly the longstanding kind of nature of the work that the outreach teams have done. We have outreach team members who've worked with COIP for 30 years, and to be able to have that kind of relationship really helps build trust for folks who have often experienced trauma in medical settings and have been treated badly in different healthcare settings. So to be able to have that relationship and trust, and then we can build off of that and really reach people, that is, I think, a really critical piece. Another component to the model that works really well is our ability to offer a variety of services in one spot where people feel they can come and get whatever they need. We have folks who come in, as Abigail mentioned, maybe come in for a wound, and then over time eventually say, okay, maybe I'm ready to try starting treatment for opioid use disorder, and then they get on Suboxone. We have other folks who come in seeking OUD treatment, and they have multiple kind of medical conditions that they haven't been seen for years that we're able to start addressing. So to be able to really meet the whole community where they are and adapt our services to see what we're seeing as the needs and offer what we can to meet those needs for everybody that we see.
Fantastic. And I think as we're thinking about this, we probably need to think about how the current crisis system, especially the crisis units that may be coming into a particular, as a response to a particular call or incident, how they could possibly start creating some of that community, right? That brand knowledge in the community. I want to switch over to Dr. Gastala. So Dr. Gastala is a practicing primary care physician and board certified addictionologist. Excuse me. Do you see the need for more comprehensive expansion of the model? For example, connecting to other services? Or how do you see these services fitting within the crisis response continuum?
Yeah, I think that's such a good point, is when we think about people who are accessing services, we want to think about their whole health, right? And the whole person. And so how do we develop partnerships? How do we ensure that, we are addressing, if they're ready and want to, the underlying trauma that they've experienced that has, resulted in a substance use disorder or caused it in many cases? And how can we help address those social determinants of health that impact their recovery, right? So housing, food security, things like that. So one thing that I think is really helpful is to have those sort of social services either available or through partnership, and again, readily accessible, thinking about how do we reduce as many barriers as we can. Patients may not have a phone to be able to call, so handing them a sheet with a phone number to receive services is not necessarily going to be the most efficacious for them, right? So it might be that you need to organize where there are teams that come out and meet with you as part of the mobile units. The other important factor is that many times patients haven't necessarily had such a great experience with the healthcare system. They've had, experienced discrimination and stigma in the EDs and hospital systems, and that can really leave a sort of negative, feeling for them for wanting to access services in general. And then that really impacts, their preventative health, right? Screening and treating diabetes, hypertension, colorectal cancer, screening for breast cancer with mammography. And, it's really, we want to make sure that we help patients live their best lives and create those spaces and those connections with health facilities to support these patients and a non-stigmatizing and trauma-informed approach, and then create pathways for them and support them through transportation, through case management, to be able to really access all the things, again, to help them live their best lives and to treat the whole person. And so I think that it's a really critical piece. Medication is just one part of it, but it's actually, the whole continuum and how we support patients.
Thank you, Dr. Gastala. I'd like to ask you a little bit, as we think about the continuum, and our previous speaker talked about, there's the crisis and then what happens after the crisis, and how do services continue and really wrap around the person. Can you speak a little bit to MAR now and how you see it fitting in with mobile units?
Yeah, so one of the great things about MAR now, this is a hotline that is through the Illinois helpline. So you can call 24/7 if you're interested in receiving treatment services. And as part of that call, if you identify that you have an opioid use disorder or alcohol use disorder, and you're interested they'll ask you if you're interested in talking with someone, with a clinician and a case manager right then and there. So then that reduces that barrier to accessing treatment, for those patients. And so MAR now is a great tool for hospitals, ERs, mobile units, the crisis continuum, because part of that system is a case manager that then helps the patient not only access medication or if they're interested in withdrawal management or residential treatment, it helps them connect to care that they're interested in and connect to medications, connect to a clinician right then and there, and then get connected to the pharmacy to get that medication, or a methadone clinic if that's what they choose, and then get connected for follow-up. And the goal is really to get connected in the community where they live, so that then they can get and receive services much more easier in the future. And so having that ability to be able to connect patients, if, for example, Dr. Messmer's team is only out on a certain area, 3 days a week, then they can give this number to their local, community members, to their patients, to then say, if you lose a prescription, if something happens and you can't make it to the van back in time, that can serve as a bridge, because we know that patients who don't have access necessarily to their medication are at high risk of relapsing and then at high risk of overdose and death with that. So having that opportunity to be able to use this as a bridge, as an initiation, as a connector point, as a safety net, right, for mobile units or hospitals and clinics and patients in general, no matter where you are in the state.
Thank you so much, Gastala. Dr. Gastala, this is I know this has been one of the critical programs within Super's portfolio as well. I'd like to switch back to the COIP team. I'd like to see if you could also speak to how you see the comprehensiveness of your model fit within the crisis response continuum, or like what can the current mobile crisis response teams can incorporate into their work?
I can speak to this. So I think particularly in the context of when working with people who use drugs and responding to folks' needs, I think this concept of meeting people where they are, which is core to harm reduction and really core to what mobile crisis response teams are doing, it says a lot, right? So not just physically meeting people where they are, but also in a broader sense, really trying to bring that full spectrum of care in terms of recovery to that person in that moment. So having harm reduction be a key component, no matter where someone is in their recovery journey and what's going on, having, even in a practical sense, having those harm reduction supplies on hand, I think is critical. But in terms of comprehensiveness, I know Dr. Gastala just mentioned MAR Now and the ability of these teams to then connect people immediately to treatment, whether that's through coordinating with our medical unit or with the MAR Now hotline, and really taking that opportunity to offer essentially the full spectrum of resources to folks for their substance use. I think the other piece from our model that could potentially be applied is this responsiveness to other medical concerns or issues that are coming up in the community, because we've really had to adapt and be flexible based on what we're hearing back from the folks that we're seeing. So an example might be wound care kits. We see a lot of injection-related wounds, and that is a way that we often see people frequently and connect with them by offering wound care supplies and some basic wound care as part of what we're doing in our assessment. We did this as well with COVID, just having COVID testing and vaccines available. You may not think like an OUD focused van would be where people would go necessarily to get a COVID vaccine, but we had a ton of people who were really interested, and that's the place they got their vaccines and then engaged in other care. So I think those would be a couple of thoughts that come to me.
Thank you so much, Dr. Messmer. A couple of other questions for the COIP team as well. So how do you see the mobile units fitting into the crisis continuum? Or do you see a place for them in the crisis continuum?
I can speak to this one. I definitely think so. Specifically thinking about kind of the aftercare. We are consistently in the communities and based on our interactions with patients, there are folks that can't or won't access care in a traditional sense. At a traditional clinic, with pre-scheduled 20-minute appointments that you have to have follow-up at a certain time or else you're not welcome anymore. So when folks are responding to someone in crisis, I think the COIP mobile units can serve as a referral source. They would serve as kind of that aftercare as well. And, help patients access care when they are ready to engage. I also think crisis response teams can let us know if there are priority areas that they're responding to frequently, if there are services that we should be providing in the areas that we're already doing outreach that perhaps that would provide even more comprehensive care. Folks on the ground are going to know best where we should go and what we should be providing. So we're happy to try out new areas and try to incorporate as many services as possible based on what those response teams are seeing.
Thank you. Now, as the team is speaking, it really does bring to mind that there is a need for comprehensive services, even comprehensive services that are being provided out of mobile units. As you see this, what would, when you start connecting people outside of the mobile units, how do you do that, and what do you see that as most effective?
Yeah, certainly we can only provide, we do as much as we can on the van, but it is a van, right? So there are definitely things people need that are outside of that. One of the benefits we have is COIP already has recovery support services across all of its sites. And so we, for folks who need a higher level of substance use treatment care, we can connect them directly with a recovery support person who's often out in person on the van, that then can connect them either to intake for a residential program, or, in some cases, even arrange transportation to get that person that same day into treatment. So that's a big benefit. And our recovery support services team really know that whole landscape within the city quite well, and are very comfortable navigating the system with folks. So that's really helpful. In terms of additional medical care. So we have a few situations where this comes up. We do a lot of primary care on the van, but there's obviously some limitations. We don't have an X-ray. We can't do mammograms on the van, things like that. So some people choose to come for their main visits to the van, and they don't necessarily want to transition to a different brick and mortar site. And then we can refer them for those types of services through the broader UI health system or other local clinics that might fit their needs. For folks who do want to establish primary care elsewhere, we've established some kind of warm handoff and quick access linkages to other clinics, Mile Square being one of them, especially for folks who are interested in methadone and primary care. We use the Mile Square main site as a referral quite often because people can get that at that same location. We found that having those warm handoffs and connections can be really important for people to get from one place to the other. I think that is often we often find people not make it to those referrals if they're too far away or if it feels too different from the van. And so we have kind of developed connections with places that maybe feel a little bit more in between. We do have some of the same providers actually who rotate out with us on the van and then are in the Mile Square Clinic. We have the addiction fellows, for example, at UIC, and that can be helpful to say, hey, you saw this person, it's the same person, and they're going to be at this other site. So having those types of bridges can definitely help. But I would say across the board, we felt like people were going to come to the van to start treatment on buprenorphine and then want to get plugged into a different site. And we found that the majority of folks prefer to keep coming back to the van, at least for a period of time, until maybe things in their life have changed a bit, and then maybe they're interested in transitioning elsewhere. But maintaining that active referral network kind of and thinking and getting word back from our patients too about what places have they had good experiences is kind of how we navigate that.
Thank you, Dr. Messmer. I want to switch gears a little bit now, and I want to talk about data. So for the COIP team, what type of data are you collecting or reviewing, and what does it say about the model or the services being provided?
Yeah, I can take this one. I think now is when our slides are going to be super helpful. So if we could share our slides again. The data really starts on slide 7. But we collect data on our patients, including their demographics, their substance use history, why they're coming to see us, and if we dispense buprenorphine directly to them. I'm wondering, maybe Pete stepped away. I can kind of walk through our demographics here. We have seen between when we started in June 2021 through May of 2025, we've seen 1,710 unduplicated patients. That equates to about 4,831 visits. So we know that means that patients are coming to see us more than once. Pete, you're back. Could you share our slides and go to slide 7? I think that'll be useful for the conversation.
I would love to.
Thank you. You want to go to the next slide, please? Awesome, thank you. So you can see our demographics for that population here. An average of about 46, 47 years old, about 68, 69% male. and a majority Black, white, and Hispanic populations. We can see that this really reflects the communities that are impacted by overdoses in these areas, and we're conducting research to explore how we can integrate and tailor our services specifically for women who use drugs. That doesn't, just because we're seeing fewer women, that doesn't mean that they are not overdosing and don't need care. So we are exploring their experiences with drug use to see how we can best tailor our services to them. You can see the insurance status here. A majority, about 65% of our population are insured. Of that population, 83% are insured by Medicaid, which also reflects the population in that area. Looking at the substance use history, we recognize that we're serving a population that mostly insufflates or snorts their opioid. This is important because this kind of differs from populations in other regions of Illinois and in other regions of the country. We can use this data to kind of better understand the unique experiences of Chicagoans, particularly on the west and south sides. You can also see this population also mostly uses other substances in addition to opioids. We don't collect a specific substance that they report using, but anecdotally, I can tell you this is mostly cocaine use. So this means that we need to continue to think about other services that we can integrate to help patients with cocaine use disorder, benzodiazepine use disorder, etc. Particularly since there's a rise in stimulant-related overdoses nationally. If you want to go to the next slide, I'll kind of talk about the services we provide. This is in that same time frame since we started till May 31st of 2025. About 3/4 of our population come to us for OUD treatment, mainly buprenorphine. And then you can see it pretty significantly drops after that. We see people for medication refills. We often are dressing wounds. Most people are coming for us for just that one reason, whether it's a medication refill, whether it's buprenorphine, whether it's a COVID vaccine, etc. But we do have a significant portion of folks who are seeing us for multiple reasons that you can see there. But still, it's mostly one or two reasons that people are coming to see us. If you want to go to the next slide, I can talk about our buprenorphine dispensing. We partner with family guidance centers to dispense buprenorphine in different day supplies, so 7, 3, and 2 day supplies. In the last 3 years, we have dispensed about 1,700 packs of Suboxone or buprenorphine, and that totals almost 24,000 films. So we think that's a huge success for our patients and getting them access to treatment. If you want to go to the next slide, I'll talk about specific data. We also collect why we didn't dispense to someone who is coming to us for buprenorphine treatment. And we can see that most folks who we didn't dispense to, we did so because they need a longer day supply than perhaps we can provide. If people are following up with us frequently, we have a number of individuals who are requiring a 14-day supply, sometimes even 28-day supplies. So in that case, we send a prescription to the pharmacy if they have an ID and are able to pay for it at the pharmacy. We do have folks who require less than or more than 3 films a day, which is what we provide in these packs. So in that case, we would have to send a prescription to the pharmacy. And I'll also speak to the other category there, since that is 20%, almost 20% of this table. This is mostly patients who, after speaking with our team, would really rather start methadone. And that's perfectly fine with us and appropriate for them. So in that case, we refer to our recovery support team or the family guidance mobile team that starts folks on methadone to then bridge them to treatment. that is kind of all the data that we have collected so far.
Thank you, Doctor. That, when we provide services, there's always need to really talk about the data as well, right? To see if our services are having an impact. So at the last couple of minutes, I know we want to leave a little time for question and answer. My last question is for Dr. Gastala. And the COIP team can also add in any information they might have or that you might want to add. So are there mobile services provided in other areas of the state? Because I know so far we've really focused around the model, but it's also COIP service area of the Chicago area.
Yeah, that's a great question. So there is another one in the central part of Illinois that's operated by Family Guidance. And then there's more that will be coming through the opioid settlement funds. There was additional units, one for Winnebago County. And so you're going to see more of them present across the state, really to impact those high need areas. The one challenge is, as you can imagine, that there is a time component of it, right? You have to get the units built to certain specifications. You have to get the DEA out. They have to then license it, security systems and all of that. So there's an administrative burden that is part of the process, but the goal is to have them representative across the state.
So do you see that those same burdens applying to possibly other models, or do you see other models that are being used across the state?
There are different models. So COIP is unique because they have multiple different services on them, right? They've got primary care, they've got preventative, they've got wound care, infectious disease. Not all of the units have that sort of staffing model. And so some of them, it's more focused just focused on harm reduction and MAR services, and then utilizing the local resources to connect patients. So it really just depends on the need of the community, the organization, and the staffing model that they're able to sustain.
Thank you. Also, what I wanted to see, as far as when we think about these models and we think about programs, and sometimes we do fund single programs or we fund limited programming. I'm just wondering if you had any ideas of what it might take to scale this model across the state, and what does that really mean when we say scale, right? Because I know we have conversations around desert areas in the state, if there really are desert areas, because if you consider OBOTs or office-based, let's call it MAR. So what do you think it would take? Outside of money.
I was going to say that was my one answer. The first thing would be funding, right? So these units, as I'm sure the COIP team can attest to, are not self-sustaining through just billing because of the patient population. So really an investment from federal or state is really required in order to get that throughout the state. The other thing that I think is really important is community involvement, making sure that the communities, that there's one, a need, but two, that they're open. You do run into challenges with a not in my backyard sort of situation where are you going to put the unit, right? Like, we don't know if we want that kind of unit. And so having those conversations, I think early in breaking down that stigma is incredibly important to be able to address the needs in multiple communities. And then the last thing I think is really getting the feedback of those who use drugs, right? How do they want services? Where do they want services? Where are the gaps? Will they use this services, or are there better ways that they would prefer to be offered services, and really utilizing their voice in order to be able to guide, in addition to the, data that we have in terms of overdoses and gaps. And then one last thing I would say is access to methadone. We don't have methadone in all counties. And it's really important, I think, for patients to have access to all 3 FDA approved medication options, right? All of the different classes, so that they can then make a decision about which medication is best for them, and not living in an area that where it doesn't have a methadone clinic really just can impact that. And there's federal, legislation that has been looked at to see if addiction, clinicians can prescribe to the methadone to be able to, reduce those barriers of not having that access. And that is, of course, being debated, but it is a great way to fill some of those gaps.
Thank you, Dr. Gastala. I don't know if the COIP team had any quick last comments. Okay, so I think one of the things that really this presentation brings about too is the need for community and collaboration and relationship. And I know that for crisis teams, that can be pretty difficult because, again, mobile crisis teams are responding to a crisis in a moment and they go. But I think the ongoing need for a continuum of care, like, again, as previously stated, that, what happens after the crisis, and then also collaboration and relationship, really developing relationships within the community. I think we know relationship works in therapy. It should just kind of work all over the place, right? We're social animals, and relationship is critical. So I don't know if there's any questions, if anybody in the Q&A. I actually can't find the Q&A, Pete, right now in my Zoom options.
No, folks can offer questions via chat for the breakouts. I should have clarified that, Dr. Rivera.
No, that's quite okay. Okay. I don't see anything in the chat. Can we also allow folks to kind of get off mute and ask a question if they feel like it? I know that's part of the prescribed process. I'm just asking.
Let's go rogue. If anyone wants to ask a question, please raise your hand. I think I'm able to unmute you.
Well, I don't see any raised hands. And so
Identify yourself in the chat, and I'll also do that.
I don't see anyone in the chat either, Pete. So I know we did a very comprehensive presentation, and so there might be no questions just because it was comprehensive enough. But I actually, in the last 3 minutes, I'd be curious. And again, Pete said we're going rogue. So as far as mobile crisis units, is there anybody in this group, in this breakout, that is part of a mobile crisis unit and might want to just kind of say a comment or two about how you see, if you saw anything that really connected with you?
While people are waiting for that, there is one question from Krista Petridge. When working with mobile units, on average, how many clients would you see on a given day?
I can maybe speak to that. On the West Side mobile unit, it really ebbs and flows according to the time of the month and the time of the year. In the winter, it does average maybe 2 to 3 patients per day. We're out from 11 to about 3:30 every day. In the summer, it can get up to like 12 to 14 average per day. So overall, the year, maybe 7 to 8 would be the average. On the South Side, we're still a new service, so we're still trying to build that community trust, since we've been mostly on the West Side for the last 3 years. But that has been a little slow to start. I would say it would be an average per week of maybe 1 to 2. We are doing a lot of harm reduction services, less opioid treatment services, opioid use disorder treatment services. Lots of harm reduction engagement, less medical services.
Yeah, the numbers would be much higher if you're counting all the harm reduction and just kind of talking with people as well. But for actual clinical visits, yeah.
And in the last 15 seconds, how far south do you go? Asked Dr. Lavender.
That's a great question. I don't know if Al, if you want to speak to that, because you're the one who's really on the ground down there.
Yeah, actually, we are in Roseland right now, so that's kind of like the furthest south we've been, and we've been as far east as the South Chicago community.
Well, thank you. I think, Pete, you said we probably have 5 seconds left, or we might be running out of time. So just wanted to thank everyone.